have spent 8 years accumulating a lot of certificates because I had a bit of imposter syndrome over it all. So I'm now trained in a lot of mostly somatic modalities because I feel like, especially in the communities where I'm drawn, that seems to be an amazing door. So that's why I'm excited to be on this panel and with one of my teachers.
So I'd like to get a feel, we're kind of an intimate enough audience to have a little bit of a check pulse of where you are. So there are studies that have shown, even in different CBT listservs, that up to 30 to 40% of the practitioners are either using or interested or finding out more about some of the different alternative somatic modalities. And I'm just curious if I could just see a raise of hands. How many of you have either dabbled, studied, experimented with any of them? Very few. Oh, there we go, more. Okay, so about 25, 30%. So that's what we're seeing about. I think that perhaps even listing, defining what we mean by that would be a good starting place. I serve currently as the chair of trustees of an international EFT organization. I served on a board for which an organization, the Association of Comprehensive Energy Psychology, of which was where we met actually. And in that, there's a great variety of people that are interested in complementary approaches that include mind-body interface in different ways and energetic ones. And I was part of, actually, with Lori, we went for about 2 years. We were on a subcommittee of even trying to better define this, because when we use terms, many of the more energetic terms, we get an automatic cognitive dissonance of like, okay, that's something weird or different that's changing. But many of them are just body-based, somatic. We were actually calling cognitive, somatic, emotional, energetic interfaces, right? To try to really more fully describe the different levels that we're working with another person. So what would be some of the modalities you either explore or work with and want to share a little bit about? Anyone who starts?
Sure,
there?
I'll start. I mentioned energy psychology, and I want to just recognize that that's a field of practices, right? It's an umbrella, and that's what we're going to talk about, our individual practices. And again, I say I practice energy psychology techniques because I'm not licensed as a psychologist. So some of the things that fall under that umbrella that I've studied, I originally was trained in EMDR. I see a lot of EMDR stuff here today. So that actually falls under this umbrella too, if you didn't know that. And I had the opportunity when I was really young to teach and train thought-filled therapy under one of Dr. Roger Callahan's students. So Dr. Roger Callahan was the creator of thought-filled therapy, which is the grandfather to emotional freedom techniques, or EFT, which I'm sure you'll talk about in a little bit. And then I went on to be trained in what was called comprehensive energy psychology. So this was sort of an overarching training that involved meridian-based therapies, chakra work, and working with the biofield. And we know very little about the biofield right now compared to the other two, but we're learning, and it's very complicated. I'm sure there's a lot of different physiological processes and internal and external things that influence the field. But if I can just throw out two names of some researchers that, if you're interested in that, Shamani Jain has a nice body of work looking at the human biofield. And also William Tiller is one of my favorites. He's written a few books. He was a physicist at Stanford. So it's very cool to see some of this research coming out of a hard science lab. So I primarily stick to those modalities, which, again, under the comprehensive lens, there can be a lot that falls under there. I've been exposed to a lot under the umbrella through my career, and I keep coming back to a few of the tools that I learned earlier on because they seem to stick and work really well with my population, and I like simple. Right? And I give my clients homework, so it can't be too complicated that they can't learn it and take it home for themselves. And then the hard part I actually had was, of a clinician too, was, which ones of these do I use? Do I keep increasing what I'm doing, and then I have too many things to choose from? So that was personally, less was more for me, and that's where I am with treatment. I didn't mention this, but I also teach a group fitness classes. So I'm a yoga instructor also, cycle, Zumba, bodyworks, all of those things. So it's interesting to learn the yoga later after being a student of these other techniques for so long. So, yeah.
I'll just add, and then I want to swing it over here. When we look at the energy psychology term as an umbrella, Really, what I would say is the only thing that they have in common is somehow there's some intention that is sharing some therapeutic knowledge that has an energetic aspect to it. And whether it's using the biofield, whether it's using what we now refer to as the premovascular system, which really is a newer research term for the meridian system, that we're standing on thousands of years of energetic aspects of human healing and things that are still learning to be measured. But there's a really wide variety of different ways of stimulating and working with those systems. And practices from Qigong and all sorts of traditional Chinese medicine methods, et cetera. And one other aspect of stimulating, whether it be through touch, on touch, or distance, is through repetitive stimulation. And that's why you'll hear the word tapping out there, right? You could call EMDR switching. There are a lot of different ways to describe it. Just easily describes the manual stimulation, the mechanical stimulation of certain parts of the body. So EFT is one of the methodologies, but clinical EFT is not the same thing as tapping, because tapping can mean drumming on your thigh and doesn't have a clinical application. Shampoings don't have the same effectiveness as the ones that we use in the clinical trials. But just to kind of hold the context for that. But there are many other methods, and why don't you share a little bit about from your perspective?
Well, and I'll piggyback onto what both of you were saying, because one of the doorways for me was actually, what are the ancient ways of knowing? So I started, like when I was in family medicine, I studied to be an Ayurvedic counselor, because I was like, this is 10,000 years of knowledge. And so I didn't do like yoga as a therapy, but I was like, what is the body of knowledge that's associated with this? And it was really interesting, because one of you is going to talk about polyvagal theory, actually tracks all the way back to 10,000-year-old gunas. So this knowledge is just constantly being reinvented, usually by a certain demographic. And it's ancient. So I did study Qigong. I'm a Qigong group leader. But in terms of specific therapeutic techniques, I do the havening techniques. As I mentioned, I do EFT and matrix through Craig. I'm level 1 trained in sensory motor psychotherapy. I do something called tension releasing exercises, and that's like an internal tremor, the way like a dog or a horse would release their sympathetic tone. Huge fan. I do, so similar to accelerated resolution therapy, that's using the eye movements to help you change associations. Flash technique does that with blinking. Deep brain reorienting, that's Frank Corrigan's work, and he uses like turning the head and kind of changing all the muscles of orientation. So when you would be looking in the direction of the event or the relationship causing trauma. And he's also the researcher behind brain spotting. So I'll explain a little bit more about that. So those are my somatic tools. I have some cognitive as well, and it is a weird amount, I know that. But part of my work in the world is just to help people gain a bigger toolkit, and hence my book being called The Modern Trauma Toolkit, is because a lot of these things you can DIY, which we'll hopefully demonstrate.
I think that's a really important point that I'd like to make. So I'll speak through the EFT lens for a moment, just because it's widely utilized out there by many people in the world, and fortunately and unfortunately spread widely on YouTube and social media, sometimes accurately and sometimes not. That there are really, I quantify as two primary divisions within the EFT world. One is the instruction for a client to self-apply. EFT tapping is a self-regulation, is a neurophysiological self-regulation tool, which is really critical, and not all techniques have homework and things that you can assign your client in order to self-regulate in times of stress and distress, and anxiety and fear and a variety of emotions. And then there's the clinically therapeutic use of that, depending on who's applying it and what their scope of practice is, whether it's more of a coaching model, whether it's more of a psychotherapeutic model, whether it's more of a performance model, whether it's a trauma reduction model, and those applications. So there's a really wide array about how many of these tools can be used, in a beautiful compilation of, as you're saying, the trauma release technique is something that you can really teach people and clients how to do themselves. And especially for me, seeing clients even with a week in between, that's a lot of time for some people to not have any tools that they're self-applying when they're in times of distress, crisis, et cetera. So I think that's a really important piece that when I'm teaching practitioners and therapists, et cetera, I think it's critical to not teach, to not simultaneously use the application therapeutically, as well as teaching them how to teach for clients to self-apply is missing a really important advantage of many of these techniques. Is that your experience?
Yeah, I just want to talk about some of the research that's out there with thought-filled therapy, but it speaks to what you're saying about the application and teaching of the groups. Some of our colleagues, I'm sure you know them too, Carolyn Sakai, Suzanne Connolly, and Barbara Stone early on went and trained a lot of members in Rwanda to be able to use these tools, the thought-filled therapy. So let me just explain. Does everybody know when we're saying tapping? Have you heard? Yeah, everybody's doing this. Look at this. So these are meridian-based techniques. Instead of sticking the needle in like acupuncture, we're doing this. Thought-filled therapy. What I actually blend thought-filled therapy and EFT. EFT is a more generalized. We're going to just tap every point and get to an end result, whatever that is. Thought-filled therapy is a little bit more prescriptive. It's a little bit more diagnostic for different clinical populations, and that's why I use a lot of aspects. But this research was really cool because not only did they go there, but they taught these community leaders how to use this tapping for these victims of the genocide. And so they really had a huge reach. And I can't remember exactly what the year was. I want to say it was the late 90s, early 2000s that they did. Yeah, and it was just some beautiful research. So if you are so inclined to look that up, it's really moving. But the difference, the tapping, it's people ask about it all the time. How does that work? Does it work? I'm a clinician, right? So if you think it works, that's good enough. Is there research? Yes. There's a lot of it. So that's been my experience that, what works for people, what they can take home. I also give homework and can package, okay, here's what you're going to do this week, because a week is a long time, right? For those of us who are clinicians and, we expect some movement, right? We have goals, which I'm very goal-driven as a behaviorist. We want to reach some sort of level of healing, or I use a SUDS level, subjective units of disturbance, and we want that to come down and stay down if we can for the most part. So a lot of this homework is geared to doable. What can you do? And maybe we change it a little bit every week. But I also want to say that I like to educate my clients too. And I do that. I don't know if this is a good time to talk about this, but I like to roll things out systematically. And we've talked about a lot of legal things today. So the first thing I will say is practicing these energy psychology techniques. I was advised early on, and this was really good advice, to have a separate consent form, or put it in your consent to treat of specifically what modalities I'm trained in and what I'm doing. I actually chose to have two separate consents. So I have my regular consent for therapy, and then I have what I call an energy psychology consent form. And on that form, I explain what I do. I quoted a website, here's what the definition of this is. And because I work with a lot of ASD families, and of course they come to me and say, can you try this with my child diagnosed? I do have a clause in there that there's no known research to me that we've done clinical trials with this population. Some people say, I don't care. Can you try it anyway? They sign the release. Some people say, So that's step one. Step two, I explain what we're doing in a very general way. I'm not saying, okay, here's all the meridians. This is what this is. This is how old this is, the history, the chakras, all that. This is where the art form comes in, right, with therapy, about therapy readiness. We talked earlier today about crisis and when is a good time to talk to somebody, not when they're in crisis, right, and to provide psychoeducation. So as the person becomes more ready, as we sort of deactivate the amygdala, we're talking about polyvagal theory, and they're ready, I want them to understand what they're doing and why they're doing it. So that speaks to the toolbox of homework for me.
You mentioned something about research. If we look at the field of energy psychology, there's over 300 peer-reviewed papers now. There's clinical trials of energy psychology methods. There's over 125 clinical trials. EFT's got, I think, approaching 80 now. There's, just to give you some sense, because people go, oh, that's probably none, but that's actually not accurate. There's now 5 functional MRI studies. We've got several cortisol reduction studies. We've got brainwave studies. We've got epigenetic studies. So there's actually quite a body that's growing without having a huge industry to support it.
And compared to some of the other psychotherapeutic techniques that were taught in graduate school, that's some substantial research. Yeah.
I wanted to just talk a little bit about how, like, theoretically, how this might, we don't know how many of these things work. Most methodologies, we can't say absolutely how that works, but theoretically, do you want to discuss, maybe just take a little bit about hypothetically what we believe is working? Because when we look at the efficacy, and we look at the speed, and we look at the duration, some of the studies sometimes stand out as unreasonably positive. I mean, I remember speaking to one researcher that was working, Dr. Church, on a PTSD study, and the reduction in 6 weeks on the, it was the short form PTSD study, it was like an 86% reduction. I mean, it was real. I mean, he said, I wished it wasn't so high in the study because it came out as totally unreasonable, and yet it was, and not all are that high. But cortisol reductions come out pretty steadily, anywhere between 20 and 40% with short interventions. So we're trying to understand how this really works quickly, effectively, and there are no studies showing significant side effects. So we start to look at those things, and it seems unreasonable, and yet we see more and more clinicians all the time adopting and starting to bring it into their practices because they're finding it clinically effective. But where would you like to take that? There are a lot of ways we can go with that.
A couple of thoughts coming to mind. So there is a lot of basic science research that's emerging. So Ruth Lanius's lab in Southern Ontario, she's mapping the brain pre and post PTSD with different interventions. And one of the things she loves to study is somatic treatments. And I think more and more clinical researchers are heading in that direction because, especially with a brain who's been exposed to trauma, the cognitive pathways aren't available. And Ruth's lab proves that. Like, you actually disconnect your midbrain structures from your prefrontal cortex once you've been through trauma. So why would it make sense that you can engage in cognitive therapy right away? You actually have to depotentiate the associations in your amygdala and detach them from the memory before you can then even access it cognitively. So once you kind of understand that very basic premise, it makes sense that bottom-up or somatic tools should be the first doorway to walk through so that you can then open the door for cognitive restructuring. So the way I always explain it to my patients, because they're used to being told cognitive behavior therapy is the only thing that works, and no. For one thing, it doesn't work for everybody. For another thing, for somebody who's been through trauma, it can feel like gaslighting to be told, well, there's something wrong with your thinking. I prefer the cognitive structures like NARM that say, wow, your thinking makes a lot of sense. And what else is available to you? Nothing's available until you've actually shifted the nervous system. So to me, I explain it as being shifts in the autonomic nervous system. Frank Corrigan's done a lot with the brainstem and where your visual and auditory input comes in. So that's the basic science behind brain spotting, flash, DBR, probably some of EMDR and art as well. When I started doing art as a family doctor, I was just doing it off the side of my desk because I was like, my patients need this, so I best train in it. And I was getting like close to 100% resolution of PTSD in a single session. And I was really freaked out because I was like, have I just helped them like buy into the placebo effect? But I've been doing it for probably 6 or 7 years now, and like greater than 90% efficacy in a single session. And these are refugees, like people that I, pre to knowing how to do accelerated resolution therapy, would have thought would be immovable trauma. So the clinicians doing this work are finding it efficacious. The science is emerging. One of the ways I explain it to patients is, as a physician, I might order an EEG and measure the brainwaves in your head, or I might order an ECG, and you would expect those things to happen in a hospital. So why doesn't it make sense that I would do an energetic treatment for you to shift the energy in your nervous system? We're starting to be able to measure that as well. So I have to use very science language. I don't tend to use the words energy psychology. I just say I have somatic techniques as a part of my toolkit. But I mean, we've all got different licensing boards and credentialing and issues like that.
Yeah, it's interesting. I mean, you look at the work of Dan Siegel and Bessel and Stephen Porges and Peter Levine and Ruth and on and on. And we're looking at these really cutting edge trauma and David Berselli and on, that these cutting edge trauma therapists, I understand that the conference we're really looking not to trauma but post-trauma. That's very much the theme here. And yet there's a, to not mention having tools to work with traumatic memories to be able to change one's relationship to those traumatic memories is a significant part of what we're doing with these many techniques. And then there is, how do we take them, how do we bring them and resurrect their resiliency and then take it into, which I love, I've been hearing more here and didn't expect, that post-traumatic growth and movement even to greater interpersonal connection, greater spiritual connection, et cetera, and starting to take it those next stages. And so depending on when somebody's presenting and what population you're working with, maybe anywhere in that scale that you're working. I get to work with a lot of chronic pain patients having that background. And, the first stage is always get me out of pain. I don't care what it means. I don't care how you do it. I don't care about the emotional aspect. So there's often a very physical intervention for me first, wearing that hat. But then we usually hit a plateau in which there is chronic states of heightened emotion, whether it's fear or hopelessness or worry or so many emotional aspects when dealing with chronic pain. And then once they move through that, they start to get a sense of something more, of wanting to use the techniques that they felt to have made these shifts to then embrace things that they haven't been able to embrace, to be able to look towards self-acceptance in ways that they haven't. And so I'm just kind of curious, in your population, when you're using these modalities, somatic modalities, for what reason and what are you trying to achieve with them?
Yeah, I have a similar experience. Of course, therapists in the audience, when someone comes in the first time, right, I'm going to use the word upset about whatever, X, Y, or Z. And I want to work on this maybe target issue or this broader issue. And then for me, we were having this discussion last night, and I said, it kind of doesn't work always that neatly, right? Where there's like layers of things where it's like I come in for this, and then we talk about this a little more, and then this other layer of the onion, comes out, and then we're on to this. I feel better about this, but, we're kind of doing this. And I don't necessarily view that as stuck at first. Right? It's just other layers that have been in there and we need to address. So what I usually do, my protocol for first sessions for people is because they just want to feel better. I have 2 breathing tools that I usually use, and they integrate the left and the right and the top and the bottom of the brain. And that's why I like these 2 particular tools. The one is called collarbone breathing. It's from Dr. Callahan's work. I have a YouTube video demonstrating that. The other one is called different things. It originally was called Crook's Hookups from Brain Gym. I think that was Denison's stuff, yeah. And so these 2 breathing exercises, by the end of the intake first session, I can say, we have a couple minutes, let me just show you one, or do you want to try this? Yes, right? And I'm like, yeah, I want to do that. So we do a breathing. They said, okay, yeah, I feel a little bit better. I said, okay, this is your homework, right? So I start off with these sort of foundational exercises to deactivate. I always say, I always call this excitability or heightened rather than, stress, trauma. I just use that general word for most people. And so we're just going to take the edge off. So we get that pre-SUDS level, do the breathing, post. I say, okay, can you go home and maybe jot down your SUDS levels before and after you do this? What's reasonable? How often can you do this once a day? Oh yeah, 2 times a day? Yeah, don't push it. Right? 1 time. Let's just try it 1 time. So this starts to develop that rapport and the trust, right? I have a tool. Now I'm empowered. I can feel a little bit better. And then after that, then I said, you want to talk about some of these other tools? Yeah. If that helped, why not? Right? So you have some buy-in at that point. Then I usually go on to some simple tapping. The way that I use some tapping is I blend EFT and TFT. And I sometimes do it quietly, with no language as we're tapping, because sometimes that's just too much for some people. And eventually I build a challenge with that. So if you have a good knowledge of the meridians, they all correspond to an organ system and an emotion. And so whatever the presenting issue is, I can create a narrative around their story. And so it's like our reflection and our summarizing techniques in treatment, but I'm saying certain things at the points that target and challenge certain emotions. And I can watch them to make sure that they're safe enough, that they don't escalate too much. But if they do, never fail. The thing that I love about thought field therapy is there's a concept called a psychological reversal or a psychoenergetic reversal. And these are sometimes where there's a block, right? When we get stuck or when a client loops, we call it a lot, and they just can't get off a certain issue. And so there's a lot of different types of these reversals, but there are two that I've found that come up a lot, especially with the ASD caregiver population. And it's not safe for me to release this problem, and it's not possible. And usually this has to do with respect to care for their children. And so when we can address those, things move along a little bit more smoothly. So that's kind of my protocol in a nutshell, and people will come back and, they do it for homework. We come back, there might be another layer of the issue. This population, these caregivers of kids diagnosed and even young adults, this is a lifelong disorder. For those of you, do you work with ASD? Anybody work with autism? Yeah. And so one of my parents always says, autism never gets a day off. And so the parents are always under some kind of duress, but they have these tools, and I have a book coming out in the fall, and I wanted to present some of these energy psychology tools for the parents that are quick, this breathing exercise, these reversal corrections, because they don't have the time to do the traditional recommendations. Can you take a walk? Can you go out with friends? Have a glass of wine? Well, those aren't realistic for most parents, but let alone this population. So I've kind of condensed that population into that little toolbox that usually goes a long way. We get the buy-in, they start to ask more questions, we explain more of what we're doing. And the other thing, we've talked about spirituality today too, and I also, at the start, because we need goals, measurable goals. One of the objectives are shorter.
This should be an interesting segue.
This should be, okay.
Yeah, I want to hear about clinical goals and spirituality.
Okay, so my clinical goals, right, are reduce anxiety, all the individualized things we need, but I have a goal that I do put in everyone's plan that says this person will explore or somewhat define their belief system, spiritual, philosophical, or otherwise. So I like to leave it a little bit general. So when people are at that point, or sometimes, right, we know as clinicians, they question in the middle of all this, or they're reaffirming faith in the middle of this. So for me, it kind of is all over the place. It's not necessarily we grow and then we move on to this aspect, right? It comes into play a lot. So that's when I call this goal. Oh, remember we have that goal. Let's talk. That's a great thing to talk about today. So that's how I incorporate that. And of course, it's different for everybody.
Yeah, go ahead.
Go ahead. Okay, the collarbone breathing is very findable. The other one is either Crook's hookups, or there's probably people on YouTube that have it under over energy correction. And it's interesting because I don't know where they got that name from. It's not that like there's too much energy. I don't know who came up with that term, but it's a real quick.
You want to demonstrate?
Sure, I can demonstrate it.
Want me to hold
you want to hold it? Okay. So there's a couple. I said I wasn't going to do this, but here we go. This is great.
You could have said no.
I couldn't. No, it's easy. We'll do it. So I was taught. Let me say first. I was taught to do this by handedness. Some people do not. So if you're right-handed, for example, you would cross your left foot over your right foot, just casually. You can just be sitting like this, and you can do this two ways. It's just the idea that you're crossing the midline in this certain way. The left hand can come across, and then the right over top. So that's the simplest way to do this. When I teach kids how to do this, and people to do it at work, my adults, right, when you want to do this at work, you can't. When you're sitting like this, nobody really knows what you're doing. The other way to do this, thank you, would be that your hands are out in front of you back to back. Okay, good. And then the right hand comes over the left hand. And then you just bring them in. You can relax your shoulders. You can relax and unhook your fingers a little bit. And so then we would just breathe for 2 minutes, inhaling through your nose, exhaling through your mouth. People that have trouble doing that, tongue up, tongue down. When I inhale, my tongue comes up, top of the roof, and then just drop the tongue. So this is one of those quickies that I give clients at the end. And there are a ton of breathing exercises out there, right? 4, 7, 8, all those kind of things. But I like this one because it has this little bit of integrative aspect, and then we can move on to other somatic integrative kind of stuff. Like if they want to do yoga and, oh, I'm really clumsy, I'm uncoordinated. You know what? Do this a little bit, and then go try some of your moves and see how you do.
Christy, why don't we pass it over to you? We're talking about techniques. Anything you'd like to share, demonstrate? I think we have a small enough group that we could even try some things here and demonstrate.
Yeah, and I think the question we had talked about was, like, what is your kind of structure to your work? So my structure is using Judith Herman. So she has 3 phases of trauma therapy. The first is establishing safety, and I don't use that terminology. I just call it noticing. And basically, I'm retraining a person to listen to the actual messages coming from their body. So we all have interoceptive signals coming up to the brain, sharing what your body's up to, sharing about your external environment. Once your amygdalas are sensitized, they either suppress those signals or amplify them. So what we're trying to do is, like, what is the actual signal? And just learn to listen to that message in its simplest state again. So that's stage 1, and I love somatic work for stage 1 because so much of it gives them a sense of control over that state. So if they're suppressing or if they're amplifying, they can take a volume dial and get it to a preferred number. So I'm not saying, like, get rid of these things, because then that also makes them feel like they're being gaslit. Oh, you've got anger? Well, you shouldn't have that. Let's get rid of it. No, just dial it down to a preferred state for you. So this is where we do the establishing safety using somatic skills. And so one of my favorites for that, and I almost always introduce it in the first session, but it's currently called the havening techniques. It's basically just a soothing touch. And what I love about it, and why I felt comfortable writing it in my book, is there is really good basic science behind the havening, showing that these particular parts of your body, that when you brush them very gently, so it's the shoulders, across the face, like cheekbones and forehead and eyebrows, and then across the palm. When you brush those areas very gently, you create delta and theta waves in the brain, and you decrease your gamma waves. And the basic science informed havening techniques, but when I actually studied the techniques, they strapped a Muse headband to our foreheads, and we actually had our brainwaves projected on the screen. I mean, talk about energy psychology. We could see in real time everyone was learning how to do havening, and their brainwaves were changing drastically. So for me, I was in the earthquakes in Nepal in 2015, so I obviously had quite a lot of activation around certain triggering connections to that. And I actually got rid of them all during my training for havening. They were just gone. So what it does is it takes away that amygdala association. So that would be more stage 2, or the trauma processing work. I call it shifting. Judith Herman called it remembrance and mourning. But that's kind of tricky terminology to me. Like, I don't really know what it is you're mourning apart from the fact that your life has changed. So I just say shifting. We're shifting into a preferred state. And then the last stage is reconnecting and resourcing. And that's what I always tell my folks is, like, who do you want to be now that you actually have more choice? The opposite of trauma isn't being happy all the time. It's just having flexibility. So now that you've got choice, who do you want to be? Let's figure that out. Because so much of their identity was wrapped up in the trauma behaviors, the trauma thought processes. And once those are different, you just have more choice. So agency interventions. And honestly, I use somatic techniques for all 3 of those phases. And so towards the end, I integrate more cognitive, but I find the somatic to be an amazing doorway. And for a lot of folks, it's preferred, especially if they don't want to share the narrative of their story.
You know, especially in that 10-day window that research is starting to show immediately after a significant traumatic event, it hasn't quite set in place as strong as it's going to be. So if in those 10 days you can find gentler somatic techniques, that's not necessarily reliving, that's not necessarily talking about the entirety of it, all those things, and you can have a breakthrough in early in those first 10 days, then it might not take a hold. And movement is a part of it. I remember speaking with Bethel at one time, and we were having a meal together, and he said, one of the things, I don't even remember if it's in his book, but I'll never forget, he said, when I was studying and working with the Twin Towers, 911, he said, I was wondering why so many of the people in the buildings didn't develop PTSD as I would have expected. Certainly people did, but not. He said, I think it was the running from the building, and it was the motion, it was the mobilization, the movement that somehow dispelled through the physical motion some aspects of the trauma within that short period of time. Now that's interesting and theoretical, but I remember that conversation about how do we look at movement, how do we shift movement physically, movement energetically, etc., before it even becomes cognitively structured. And when we, similarly, when we look at some of the theories in EFT or whatever modality, whether it's memory reconsolidation, we look at that window in which we can create new connections and have a new relationship to those traumatic memories and events and shift those, then we can start to have more options and choices in that phase 3. I like that. Did you want to just show a little bit and demonstrate havening just so they can have a direct experience? Of course, I'd be happy to.
So another thing I like to do is integrate. So as you learned, I've overstudied the modalities, so I'll try to smush them together. So I use a lot of interactive guided imagery when I'm doing some of the somatic techniques. So for havening, I might say to the person, if this is our first session together, just think of something irritating that happened in the last week. And just notice what's coming up in your body as you think about what it was that developed. And so as you're paying attention to these body sensations, we're just going to start really gently brushing one palm across the other. And as we do that, we're going to go somewhere really peaceful. So let's go on vacation together. Would you like to go on a beach holiday? You want to go to the mountains? Should we go visit a lake cabin? They pick a place, and then we go there. So I'll have to pick for us, sorry. We're going to go to the lake. So I want you to imagine the sound of the birds at the lake. And just pay attention to those sounds. And just notice how many different sounds you could hear. And where you prefer to be sitting. Do you want to sit on the dock, or do you want to have your feet in the water? You could be in a canoe if you want. Where are you right now? And then we'll move up to the shoulders, really gently brushing downwards from the top of the shoulders down towards the elbows. So this is a nice slow movement. If you're in your canoe, you might be paddling a little bit. If you're on the shore, what are you paying attention to? Can you see the sunlight dancing and rippling on the water? Just shimmering and flickering in front of you. Just notice that, all of the sparkles coming off the lake. Can you see through the lake? Do you see any fish? So as you can see, it's kind of playful and really creative and imaginative. And then as you're brushing across the forehead and the cheekbones, we're going to imagine that something surprising happens. So it could be a dog joins you on the deck, or you might see a deer. Just notice if there's any other animals in the scene with you. They're going to be friendly and gentle. Who might you see? So, and then again, we would check in with the body and just notice if anything shifted or moved. I might use SUDS. I don't usually introduce SUDS at first because it's just too many concepts at once. Thank you. So that would be, an example of havening that I would just give them an embodied experience of that nervous system shift so that they then have some confidence and competence that this is something that's possible. And once you've opened that door, then they believe these techniques are going to work. And honestly, even if we're just amplifying the placebo effect, that is awesome, because I would way rather do that than prescribe an SSRI.
Can I just say one thing before we move on as a therapist? Please have your existing toolbox in place. Before you get trained in any of these things, which please get trained before you do them, because these things, as simple as they look, right? Everybody's nodding their head, yes. Can call up things like, I might pick a lake, and that, might be, we don't even know this person, right? It might go right to...
They drowned in the lake.
Something,
right
something. So this is kind of why you want to navigate how much language sometimes, too, that we use. Something else I want to comment on, this is really random, but because we just had the training, can you do these things virtually, telehealth? Yes, I can. Most people, I think, and practitioners would say yes, it's a go. So, yeah.
Yeah, that's really, boy, in the before times, so much was in person, and there was so much of fear with so many clients that how would I ever do that not in person? And yet we discovered in trainings, et cetera, since then, the safety they have at home in their own couch with their dog on their lap and their own food, it was not what I expected. And I'm not saying all cases should be done telehealth, et cetera, but I am saying we're very surprised in our field, many of us, positively for that transition. And I lost what I was going to say before that. Let me see if I capture it.
We need an EFT demo.
Yeah, I know that, and I was just thinking okay, I lost it. That's okay. So, yeah, okay, so let's just talk about where somebody might use EFT. So on one hand, a first level might be teaching somebody, so let's just say that it could have been any of you that was coming up and asked to speak today, right? So we're just projecting forward whatever anxious, worry, stress about even coming up here. I know I did a little bit. I tapped upstairs first just to make sure I didn't forget anything, got everything covered. And so I just took a few minutes to tap on that little bit of anxious that I'm going to forget something or I'll overspeak or anything like that. And so when we do this, we can tap on something that we're feeling about something forward. We can tap on something we're experiencing right now. And we can certainly, with trauma work, in other words, work on things from the past. So there are usually three targets, and the emotional learning may be the emotional felt sense. The physical felt sense might be stronger than the emotional. There might be beliefs or decisions about self. All these things are material worthy of tapping all the time. If we wanted to do something right now, just as an experience, just so you can see what the points are, I'll have to ask you to just, yeah, thank you.
Hold your mic.
You too. If you find something today that you can just think about was stressful today, you were running late getting to one of the scenarios, you overate too much at lunch, which I did. You could, something that's just to the point of stressful, but as you were saying, you know, even in doing demonstrations, the associations we can connect to other times that were much worse are always there. So please take care of yourself, and if you find yourself getting it all dysregulated, please just stop. So don't do that. This isn't the place for it. So let's just take a moment and find something that was somewhat distressing or stressful. Today is an easiest way to say it. And just notice if stress best describes that word, or maybe it's frustrating or annoyed, whatever that word best describes that scenario of what happened today. And just give it a present 0 to 10. 0, there's like whatever. 10's like really stressful. Hopefully that's not you. And it's somewhere in between. So just give it a 0 to 10. And the other part that's really kind of that self-awareness is if you allow yourself to tune into that experience that happened today and the emotion that you feel currently about it, notice if there's a somatic element to it. Notice if you feel that in your chest. See if you feel that as a feeling in your gut or tightening in your solar plexus or a constriction in your jaw. So just notice. We never force that element, but you can just become aware of that. So part of the somatic element is an awareness as well as the physical stimulation. And so I'm going to go ahead, I would work with somebody uniquely to set up what we call the setup statement, the verbal part, but I'll just have you follow me for now because that'll work best here. So we're going to start off by just using, it's easiest for your dominant hand. It's not required if you just take your dominant hand and just tap on the outside of your non-dominant hand. If you'd rather rub it, you could. There's a lot of flexibility. Okay? So some people like this. You can use pressure, but most people use tapping percussion. Okay? And so on the side of the hand, I'm just going to say a statement that just describes that witnessing. And it would be something like, even though thinking about that I ate that second half of the sandwich today, and I'm annoyed that I did that. I should have stopped before. And I noticed that annoyance in my head. I accept that I feel that way. And I would repeat that 3 times. So I'm going to go ahead and I'm just going to kind of give a neutral statement up here, but I'm going to let you do that. It's just naming the target. It's offering the emotion or whatever emotional word best fits for you. Notice and add if there's a somatic element. And for now, we'll just say there are various ways of the self-acceptance element of this, but for right now, we'll just say I accept that I feel that, because unless you don't, that it's not true for you, but for most of us, I think, in this audience, it will be. So even though, you can repeat it softly to yourself. Even though, thinking about, and you fill that in yourself. I feel, fill in the emotion, in my, if you feel it in your body, and I accept that I feel that. Or if you're okay with it, I accept myself, some level of self-acceptance. Okay, if you're okay with that. And we'll do that 3 times just to really set the frame. Even though thinking about X, Y, Z, I feel this particular emotion, I feel it as this, like a tightness in my stomach, or however you feel it somatically. I accept myself, or I accept this feeling, or I accept that I feel this way. And one more time. Even though, just thinking about the thing I'm focused on, I feel this emotion. I feel it in this area. This is how I feel it in my body. And I still accept myself, or I accept that I feel this. And then we're just going to go through what are referred to as the reminder phrases. They're a short snippet element of what we just said on the different points. And the top of the head point, so this frustration, right? The eyebrow, the beginning of the eyebrow here. It's pretty forgiving, the point. Don't tap on your eyeball, please. It's the bony part at the beginning of the eyebrow. Okay, this frustration in my gut. Side of eye, not out by the ear, not in the temple, not on the eyeball, right on the bony ridge of the eye. There's actually little tiny indents if you felt deeply, but you don't need to right now. And right underneath the eye, this frustration. And in this divot in the nose, this frustration. And on this line on the chin, and these are all meridian endpoints that are close to the surface of the skin, why they're used, this frustration. The collarbone, just bring your one hand or both to the beginning of the collarbones, just drop down and out just a little bit. This frustration. And then under the arm, whether it's easiest, take care of your shoulder to either reach across or both hands on the same side, this frustration. And that would be just a single round. And then I would reevaluate with the client. Okay, you're still thinking about that thing. Yes. You're still feeling frustrated. Yeah, not so much anymore. What is it now? Well, it was a 5, now it's a 3 or 2. You still feel it in your chest or wherever they do? No, that's kind of changed to here. And we're going to then follow the shifts, and we're going to let it unfold with the client. Often sometimes the suds goes up as they start to really tune into the focus. And that happens, nothing wrong with it. It's just kind of a tuning in phase. Sometimes it'll stay the same, because often it's about getting more specific about the experience. What is it about that experience that is frustrating? Well, I knew I shouldn't have, but I did anyway. Oh, and then we kind of refocus the target a little bit tighter as long as they're staying emotionally okay. And then it might change in the body as well as it moves around. And so we use, it's very client-led. I'm not adding a lot of information, I'm facilitating. I'm asking questions. I'm encouraging their self-awareness to the degree that's still safe and appropriate, and rapport is still there, and safety is there. But it is a very organic process that really flows and moves. And so on a very simple, that would be a very simple example. So emotional freedom techniques, there are many techniques for regulation, for trauma. That's kind of the basic simple recipe that you see most often. It would be most kind of your hammer in your toolbox. But there are a lot of tools that are taught when you're going through full training, et cetera. So that's it kind of on a very basic level to just see it. I think it's a good way to begin. I'm just being mindful of time. We doing okay? We are. Okay. What would you like to add based on that?
Well, and I like how you described that there's technique. So, like, one of the things that really drew me to EFT was there was a protocol for when people were overwhelmed and they couldn't actually tell the story of what happened. There's a protocol for cravings. And a lot of the other techniques that I've studied have similar different ways that you can go. So even accelerated resolution therapy, like the more modern EMDR, you can just do a whole protocol on the willingness to change or the belief that change is possible. Havening techniques, my most popular TikTok is something called affirmations. And I just described something that's similar to an affirmation, but you're just putting a what if in front of it. So if you can't imagine, I deserve good things, the world is a safe place for me, you just say, what if I deserve good things? What if the world could be a safe place for me? And just notice how different that feels in the body. And they often do experience that difference quite substantially. So these different techniques, it takes some getting used to the practice to know when you're going to do it, but it gives you just so many options, like this giant toolkit. One that I was going to mention is brain spotting. So the premise behind brain spotting is that where you look affects how you feel, and the way I explain it is that events and relationships are stored with a place in your visual field. So when you look at that place, you're actually activating that core memory or that core belief, and it gives you an opportunity to change it. And it's very patient-driven because the process is, there's almost nothing else you do other than identify that, we call it an activated spot, or sometimes a resource spot if you're trying to help them regulate. But there's an amazing protocol for cravings that I use at the addiction clinic, where you would actually find a spot that's linked to the feeling of craving something. So a lot of my folks are using a substance to help regulate themselves or to numb or whatever their solution needs to be. And so they'll find a spot in their visual field related to the craving, and then they'll find another spot somewhere in their visual field related to the consequences that they have experienced or that they're worried about. And then you just link them. You just have them look back and forth, and they pendulate between those spots. It's not quite the same pendulation that Peter Levine describes, because you're not going sympathetic to parasympathetic, but you're creating a neural pathway. You are actually creating neuroplastic connection between the craving and the consequence in real life, in a very embodied way. So I just love having this giant toolkit. So if a person comes to me and says, this is the thing I'm struggling with, I can pull out a modality, I could pull out a technique, and we'll just see what happens, because they'll have that experience.
I'm going to pass it to you, but I found it fascinating beginning the day with talking about poo and the psychological states associated with the health of our colon. And the degree, the science that she's doing is phenomenal, fascinating, wasn't it? It really was. That to the degree that I have bifidobacteria, whatever it is in my colon, is affecting suicidal states, et cetera, and all we're saying is that stimulating the body or the vision also has an effect on our thinking and emotional states. Like, is that really a big stretch? I mean, it's felt like to get to this level, to have this conversation, has taken so long. And yet research is supporting it, and yet there's still very strong biases that it's cognitive only, but I think it's just a matter before the the Berlin Wall just falls, and it says there are many different ways of stimulating thoughts, feelings, ideas, beliefs, decisions, associations, and these are just more inclusive. We're not saying better, we're saying there are other ways of working with them. Yeah?
Yeah, there was two things that I just want to tie together that we brought up so far. One was the Trade Center, which I'm not a researcher, but I happened to do a study on a person. It was a longitudinal study that I was part of for a person who survived the World Trade Center. And we actually combined EMDR and EFT in this study. So those of you who do EMDR, since I've been hearing a lot about that, we would actually do an EFT protocol at the point where we would stop or needed the safe place or an ab reaction. What I do in therapy sometimes, I don't use the EMDR a whole lot anymore, but that little exercise I just gave you is another tool. Let's learn that first before we start those sessions. So when you do need this, here's what we're going to come back to, and it's a trusted resource. So that's another way. I don't know what you're using for that piece in EMDR. This is really cool stuff. I really want to say, too, just to recap, for those of you who aren't that familiar, energy psychology, cognitive somatic tools, we're talking about the mind and body. So we're putting the two together, getting people in touch with, hey, this feeling here is either speaking to this, or this is causing something this way, and that connection.
I mean, I get to witness some pretty amazing physical changes happen when we alter thoughts, feelings, beliefs about something. And the next day, their physical pain is away. Because, like I tell my patients all the time, the pain isn't in your knee. The pain is not in your back. The pain is here. It's the perception of what's happening is here. So when we work with our own physical elements, I'm not going to say that every physical ailment has an emotional root cause. But I'm going to say if it's chronic, it always has an emotional element. right? Who isn't, if they've had pain for any period of time or whatever physical symptom, hopeless, frustrated, annoyed, angered that they can't lift their kids, they can't go back to work, the embarrassment, the shame. So there's always an emotional component. What degree that's going to help heal the perception of that ailment, the diagnosis and or the symptoms, I can't ever guarantee that. But if they're willing to explore that, when they are, then I'm willing to go there. I think this may we have about 10 more minutes. Why don't we just open it up to questions? And I think that would be good. So happy to talk, but also happy to take questions.
While we're doing that, yeah, I just have to get on my soapbox is usually clinician self-care too. So these are great tools to use for yourself when we do start to learn them, because I know you're all excited now to go take a training to learn some of these things. There is an effect when we have successes so quickly with clients that we get excited, and then maybe we come to a stumbling block at some point. So just be mindful of your own self-care, your energetic boundaries, troubleshooting, and have all those tools in place already for you. Yeah.
And training, for one thing, for like us, we begin with a 3-day training, but certification often takes 6 to 12 months because there's mentoring, supervision, and case studies and all of that. So there's like a first level of application immediately, but really becoming masterful is like anything else, any of the techniques. If you're interested, a quick plug, EFTtappingtraining.com is our website. Do you want to give a quick,
I do consulting too. I'm licensed in Pennsylvania, but I do consulting, especially for ASD, because there's a lot of, lack of resources that people don't know. And I do consulting with these tools and techniques. And I mentioned my book's coming out this fall, From Exhausted to Energized, the EP Caregiver's Guide for ASD. So it has a lot of these tools in just for that. And when I'm saying caregivers, teachers, therapists, parents, guardians, useful for all.
Great.
Any questions or comments? Oh, yes.
I'm curious because I've heard before in doing like EFT or even havening whether you should be doing it with your eyes closed or your eyes open, because I have heard from other trauma therapists that this could be re-traumatizing or could exacerbate your symptoms if you have your eyes closed. So I was curious what you have to say on that.
Yeah. Are you clinician? You licensed clinician. I'm going to say know your client for that. And I would try successive approximations. My behaviorist lens would say try successive approximations. Are they comfortable just having their eyes closed anyway? Or does that not feel safe to them? So I would say use common sense. That would be my
I teach with any new client, always have their eyes open. Always. I don't know sufficient trauma history or how quickly they can get trauma pulled into those. Now, if they're tuning into, like, where do you feel that stress about speaking tomorrow? And they're like, I don't know. I'm not going to say, open your eyes. Like, I'm not going to, like, rush that. But it's another thing if we're having a conversation about their past history and I don't know where they're drifting back and their eyes closed takes them away from the present moment. So I always err on the sense of safety until I really know that client and their history and have worked with them. So that's where I am. For you?
I do both. So sometimes even in brain spotting, like you'll have them gaze and they'll just want to close their eyes for a while. And for me, a lot of it's about tracking. So I try to do like really mindful co-regulation where I can see where their nervous system is going. So we try to prevent freezing or flooding. But yeah, I would say both. I wouldn't say as much closed eyes for EFT, but havening, people love to close their eyes. And you know, depending on the technique we're doing, sometimes it can feel really, really good, and they just want to have that be their sensory experience.
I would just add one more comment too with people, head injuries, head trauma too. Sometimes there's the cognitive fatigue. Again, know your client. You need to close eyes and not.
Yeah, great question.
Who else had their hand up? I don't remember. Who? Kelly.
I just want to know, I'm not a clinician, but I'm a nurse. Or I guess I'm part of the clinical team. But I see the therapists where I work use Somatic and EMDR, and I'm not sure about the havening. Yeah, the havening is my favorite. I like the havening, and we've seen a lot of positive outcomes in our clients, and they love it. it's so much so that they want to use it when they leave our treatment, and they're finding it hard to get that modality covered with insurance. And then they have to end up paying out of pocket, and it's really expensive. And so where they were getting somatic experience at our treatment maybe twice a week or 3 times a week with their therapist, they now can only maybe afford it for once a month, like, because it's $200 per session. So it's really hard. Like,
So this is why I wrote my book, and this is why I joined TikTok, is because I just want to get this information to people, especially folks who don't have the resources, because a lot of these techniques, they're going to be private pay. And
Well, could be. Right? If you have behavioral goals, if you're an outpatient clinician, I have behavioral goals, and you're going to reduce your anxiety with cognitive somatic techniques, maybe that falls under there, right?
Right.
So there are creative ways to do this. I think that therapists, quite frankly, are sometimes afraid of what they can and can't do and the languaging with that. So maybe just encouraged to look around too, because some of these can be done.
okay.
Yeah.
Thank you. 1, 2, 3, but I'll leave it up to you.
A few more.
Mandy, we call that the pretzel, EMDR pretzel.
Yes, heard
And
that too.
Love it, love it, love it. And an energy medicine person was working with me on something, and she told me to do that. I'm like, why are you asking me to do that?
That's Dawney and stuff. Yeah.
And she said
Yes.
it reverses the polarity in your brain.
Yeah.
So if you're spinning on something, it might help you unspin.
Well,
It's very exciting.
It's probably a little bit more complicated. But the way I was explained, if we really want to get technical about this, is we're electromagnetic and polar. And sometimes that actually switches. So it's maybe less of a spin. That would be considered in the Callahan world more of a neurological disorganization. That's where I'm saying, like, if you really get trained and learn this stuff, if you work with clinical populations, there's a lot of streamlined ways on how to identify, assess, and what tools to match with these more significant issues. Yeah.
And some of these will have more research basis than others. Some of them are clinically applied, but not as well documented in the research, but that doesn't mean that they don't work clinically. So we're kind of bouncing between some that are more and some that are less. I think there was a question in the back row. Oh, I didn't see that. I'm sorry. Excuse me.
Oh, that's okay, no problem. So this is a wonderful, wonderful session, and I'm like all excited. But I wanted to introduce a little, challenge for introducing this to people. I work over the phone. So I work for a behavioral health call center. We operate mental health crisis lines in Oregon and 2 counties. And chronic pain is something people bring up constantly. And I'm wondering what your ideas are and suggestions for how to introduce this to somebody over the phone. And I'm not going to be able to do it with them, of course. I don't think. I mean, actually, maybe I could, but I don't know. I wonder if you could do it over the phone.
I think you might develop some resource places to be able to send people as an idea over, let me introduce this technique. I'm not going to say, because in the day, my wife was doing this work before I did, and it was before the video, it was before Skype. And the work she was doing therapeutically was phone work. So auditory work, I mean, for somebody that's blind, it's definitely possible, but what is the time? You've got 10 minutes with somebody, so maybe one of the things to consider is resources of people, places to be able to send people. For me, people in chronic pain are dealing with, how can I make some incremental change for them to feel a little power over? And a round or two of EFT can often take it down, even if it's 20, 30% in a few rounds. And there's like, wow, if I could do that now, maybe there's some possibility. So, but it may or may not be appropriate in a call center in that setting. But that's my response if anybody wants to add.
This will be our final question, and just so everyone knows, this is the last workshop here in the ballroom. So all the rest of them for today are going to be upstairs.
Oh, okay.
I actually had 2 great resources to share. One is an app called the Tapping Solution, and they have a free version or a paid version, but you can do it on health anxiety, any type of issue that they have little courses, but they're 10-minute sessions, and it's fantastic. And that's accessible to everybody. And the second one is a book called The Way Out by Alan Gordon. He's a social worker that wrote this book about neuroplastic pain, about how, like you said, pain is not coming from your knee. Like if you have chronic pain that really you can't get any relief from, that there's some tools that you can use. It's neuroplastic pain, and there's some tools that you can use, and it's a combination of mindfulness and somatic body scanning. I've read the book and found it personally really impactful, and I recommend it to clients. It's life-changing. It cured a client of migraines. It's really, really amazing.
And if you want to train in something similar as a clinician, pain reprocessing therapy is a course that's run by Howard Schubiner. I just did his practitioner training, the advanced level. It's really helpful. And it's exactly what Craig's describing. I do have a TikTok that has like a little folder called Healing Skills, and I demonstrate things like tapping and havening if your people want to see it in a minute, because over the phone it's pretty hard to describe what this looks like. So if they just want to be able to see, well, these are the points we're tapping, these are the places we're havening. And then my book has a QR code, and it has 20-minute introductions to all of the practices, because I do think it's really quite easy for parents to teach kids, for teachers to know, police officers, like there's anybody who's dealing with the public. The public is pretty dysregulated these days. There's a lot that we can help them with.
Thank you. Let's thank our panel, everyone.
Thank you. Thank you for being
Thank
a great
you for
audience.
attending.
Yeah.